Welcome back. Hope I'm audible. So if you have any doubts, you can just put it in the chat section. We'll discuss them at the end. So today we are beginning with the interesting module of plastic surgery and burns. So technically what happens is most of the times when we are practicing and when we are actually operating the patient, we don't know the basic concepts of plastic surgery. It is not expected at general surgery level that you should be knowing how to raise the skin flaps, how to plan the reconstruction of the patient. But at least when you are going to start operating on the patient, whenever you are going to do a skin closure, whenever you are going to do the fascia closure, whenever you are going to do some subcutaneous closure or sheath closure, so basic principles of suturing, basic principles of tissue approximation is something which is to be known by all the surgeons. So we are going to just try to conclude all the skin disorders first. So in the first two chapters, we are predominantly planning to cover the basic skin disorders and skin malignancies. In the second half of the chapter, we will deal more about core plastic surgery, which is going to be your flaps, the skin pedicles, the blood supply, how are we going to raise the flaps, which flaps are there, what is graft, what is a flap, what is a split thickness graft and full thickness graft. So those core plastic surgery concepts in the second half. In the first half, we'll talk basic about the anatomy physiology of the skin, different types of skin cancers, because that comes under general surgery. So any swelling, any malignancy over the skin is first going to present to the general surgeon, and then you are going to refer it to the plastic surgeon, because then the plastic surgeon will think about reconstruction. But basic resection principles are included in the general and onco surgery. So we'll begin the session by talking about the skin physiology. So this is a very high yield table which has been taken from again Bailey Love and also with some additions to the physiology. So this table is very important if you are actually planning for a NEET PG exam, and definitely important if you are going for NEET like NEET SS, or if you are going for your MS exams. So what is the important thing? What is the crux of it? So let's see that the skin is acidic pH. So how is the acidic pH on the skin maintained? It is because of the sebum and lactic acid and the sweat. And what is it going to do? So first function we saw that it is the antimicrobial barrier. So we know that there is something called as innate immunity. So any pathogen cannot enter the skin directly. It acts as a protective barrier, and that is the reason when you are going to have trauma, you can have subcutaneous infections. Whenever you are going to have skin breaches, you will have subcutaneous infections. Whenever there is burns, there is going to be loss of skin, and the patient are more prone for developing infection and sepsis. Then important part is thermoregulation. So how is thermoregulation going to take place? So thermoregulation is because of the sweat gland. So the fluid is going to evaporate, and along with that the temperature is going to reduce. And also because of cutaneous vasodilation or constriction concept, the skin is going to be warm or it is going to be cold, and because of that the thermoregulation is going to take place. So heat and water regulation is going to happen, and it is very much important because in burns patient, the patient has a rapid fluid losses. So no skin over the surface, the water is going to evaporate like anything, and that is the reason the patient will go into dehydration, hypovolemia. And so we are going to see something which is called as a Parkland's formula in burns. So what is Parkland's formula? Anybody can post in the comments. I will be more than happy to see. So Parkland's formula. So what is Parkland's formula? Just post it in the comments. Let's see how many of you know already. So Parkland's formula. So what is Parkland's formula? That is the formula for resuscitation of burns. Then comes the hormone activation. We all know that vitamin D to conversion. So vitamin D, so whatever your UV rays are going to fall on the skin, they are going to convert the deoxycholecalciferol into vitamin D3. So skin is one of the important organ of the body which converts the existent D2 into D3 into the body itself. So we know that the first mechanism takes place in the liver, then the kidneys, and then D3 conversion into the skin. So vitamin D deficiency is seen in sun avoiding patients. We know that, and always remember that vitamin D is always going to be protective against melanoma. So we are going to talk about melanoma sometime later, but always remember that it is going to be protective against melanoma. It is again sensory function, so you can feel the touch, you can feel the pain, if it is good or if it is bad. So not the good touch and the bad touch. So basically, if the thing you are touching, if it is causing trauma to you, so you are naturally going to feel that, oh, this is something traumatic, so you are going to withdraw your pain. So it is important sensory function. UV protection. So always remember that melanocytes produce melanin, and UVB has highest penetrating potency. So let's talk something about the UV rays. So what are the UV rays? So there are two types of radiations which you are going to encounter in the surgery. So what are the two types of radiation which we are going to encounter in the surgery? One is going to be your UV radiations. One is your UV radiations, and other is going to be your ionizing radiations. So UV radiation is nothing but UV radiation means the sun which is going to come. So there are two radiations, UVA and UVB. So UVA is less penetrating, and UVB is more penetrating. So most of the malignancies are associated with UVB exposure. The skin malignancies are associated with UVB exposure, and as this is less penetrating, it is going to cause burns. So superficial burns. So many times you see that if you are going into the heat, the superficial part of the skin is feeling like burnt. So that is because of the UVA radiation, and UVB penetrates more, and UVB also causes, so UVB is going to cause cancer. UVB is also going to cause cancer. And ionizing radiations which are important are X-rays, gamma rays, and these radiations are more predominantly going to cause what is called as squamous cell cancer. And rest all the malignancies, the melanoma, the basal cell carcinoma, these are all going to be happening because of the UV radiations. So UV radiation causes what is called as BCC and malignant melanoma, and ionizing radiations are going to cause squamous cell carcinoma. So it is very much important. So whenever in your NEET paper a question is going to come, a 44-year-old male worker in the sun is having some malignancy, so mostly it is malignant melanoma or basal cell carcinoma. But when the patient is working in some radiation industries, nuclear industries, so that is the time the patient is more predominantly have to have a squamous cell carcinoma. And immunological function, the Langerhans skin dendritic cells. So whenever a pathogen or a tumor cells are going to be present on the skin, the first line of defense is going to be present in the form of Langerhans cells in the skin. So you know that the skin is divided into 4 layers, right from the below upwards it is stratum basale, and the basal cell carcinoma arises from this layer, hence it is called as a basal cell carcinoma. It arises from the stratum basale. Then comes the stratum spinosum, because the cells are predominantly spine-like shaped. Then comes the stratum granulosum. So in granulosum, one important point is you are going to find out in melanoma that from the stratum granulosum, you are going to measure the thickness of the malignancy. So important part of stratum granulosum is you are going to measure the malignancy depth from the stratum granulosum. So I am just talking about the surgical important points in each of the factors. Stratum lucidum. So what is stratum lucidum? It is the second most upper layer, and stratum corneum is nothing but dead tissue. So it is already devoid of the nucleus. So stratum corneum is the most superficial layer. So what important things we saw, that stratum basal is nothing but it is because of the basal cell carcinoma. It is going to give rise to basal cell carcinoma. The stratum granulosum, important point is you are going to measure the thickness of the melanoma from the granular layer. So we saw the 2 malignancies and importance here. So what is about the skin vascularity? So skin vascularity comes from a concept called as an angiosome concept. So what is an angiosome concept? So you can see the diagram here readily. What happens is whenever there is going to be a major artery near the skin, it is going to penetrate the muscle over the skin. So this is the penetration of the muscle. So it is going to penetrate the muscle over the skin, and then it is going to supply a 3-dimensional area of the skin which is called as an angiosome. So one portion of the skin, so 1 square meter or 1 square centimeter, so whatever that artery or that pedicle is going to supply, it is called as an angiosome. And whenever that angiosome is going to be present, so that is the mechanism of picking up the flaps in the plastic surgery. So you are going to pick up the flap based on that angiosome concept. So we'll talk about it later in the last chapter when we are discussing about flaps. But important point here is, between the 2 angiosomes there is a connection through the muscle, and that vessel is called as a choke vessel. So that choke vessel is important. So let's consider that you need a flap, but the area surface required is more. So if you are going to just take the flap from this much area, then that flap might not be sufficient for that region. So what do? You are going to, what are you going to do? You can cut the blood supply from here, and whenever the blood supply is going to be cut from here, just see that this remaining part of the flap is still going to get the blood supply from these choke vessels. So these choke vessels are going to help, and that is the time when you are going to pick up the flap along with the muscle. So myocutaneous flap. So whenever you are just going to pick up the skin, you need to take only a small portion of the angiosome. But when you are going to pick up the flap with the muscle, which is called as a myocutaneous flap, you can take it along with larger chunk of the skin, because in the muscle there are going to be choke vessels. So again an MCQ, at least for the NEET SS level aspirants, but it is important. So the choke vessel is going to extend the region of from where you can pick up the flap. So what are those flaps we know? Yes, we know the flaps which are PMMC, pectoralis major myocutaneous flap, latissimus dorsi flap. So why don't we just pick up the skin? Because the skin angiosomes are very narrow, and to extend their blood supply, we are going to pick it up along with the muscle, because muscle has a rich blood supply. So this is nothing but a skin angiosome concept. What is the choke vessel? So it is a reduced caliber anastomotic vessel which links the adjacent angiosomes. and they dilate under the ischemic stress to recruit the blood supply from the other territories. And always remember, the skin has the potential to take 100 times more supply than what it is required, because we saw that the skin is going to act as a physiological organ. It is going to help in thermoregulation, in immune system, in your in maintenance of temperature. So all these things are going to be carried out by the skin. Hence the skin has the blood supply of more than 100 times. And what is Taylor angiosome concept? So we know that there are dermatomes. In the similar way, Taylor was a surgeon who actually described that whole body can be divided into different angiosomes. So we are going to talk them in the plastic surgery chapter. We don't want to go into depth right now. So whenever we are going to talk about the flaps and the grafts at the last moment, we are going to talk about it. So what important is that the angiosomes defines a safe territory for a flap, and crossing a choke vessel into the next angiosome is possible, and that is the reason you pick up the myocutaneous flap. And always remember, but it always carries a high risk of necrosis. That is the reason whenever you are going to place a flap or pick up a flap, you do what is called as a Doppler, because you want to check the blood supply before you are going to pick up the flap. So whenever you pick up a flap from any part of the body, you are going to do a Doppler of that part. So now coming down to some benign conditions of the skin, you are going to encounter them in your OPD. So if you are a surgeon, you are going to see them. If you are a medical consultant, you are going to see them. If you are just an intern, still you are going to see the patients, because these patients present predominantly the general OPD, and then they are referred to the surgeon if they are required. So what is hidradenitis suppurativa? So it is an apocrine gland disorder. So what happens is, because of those apocrine glands who secrete the sebum, what happens is more amount of, so it is seen typically in middle-aged ovulating females and in axilla and groin, because the most of the apocrine glands are located in the axilla and groin. They secrete the sebum and it contains the typical odor. Hence you can sense that smell typically in that underarms or in the groin region, because it is because of those apocrine glands. And what happens is there are multiple recurrent abscesses. It might be related something to the genetics, but what happens is the abscess occur, there is formation of a sinus tract, and it resolves on its own after menopause. So it might be because of hormonal dysregulation. And what is there? So you can give topical antibiotics, something which is in your dermat. What are the retinoids? So it is nothing but vitamin A derivatives, and they have the potency to modulate the cell cycle. So that acts on the cycle of the cell, and it is because of that the turnover of the cell reduce, and you can give oral or topical retinoid application, but it comes with a lot of side effects. There is alopecia, there is gastritis. So there are a lot of side effects of oral retinoids. You are going to typically deal them in dermatology. The surgeon never prescribes a retinoid cream or retinoid tablet, but what is the line of management at your level? If it comes to you can give them antibiotics and send home, but if it is not resolving, then a dermatologist needs to be consulted in view of starting retinoid creams. You know that retinoids are also given in acne, so it is nothing but the same mechanism of action is going to act in your axilla. So what is pyoderma gangrenosum? So when I was in the casualty, there was a call from the medical side. So in the casualty, there is a medicine side of the casualty and the surgery side of the casualty, wherein the medicine and the surgery residents and people are going to visit. So a patient came a non-recordable blood pressure in the casualty of the medicine side. So whenever the patient is going to come to you, whenever the patient is going to be referred to you, by seeing that ulcer, you should be able to tell that is this ulcer something related to a local pathology, or is it because of some systemic pathology. So first thing, when you are going to see an ulcer on the limb or on the arms or on the body, first think about a systemic pathology and then come down to the local causes like cellulitis or necrotic infections. So similarly, the one case which I encountered was a pyoderma gangrenosum. So typically this ulcer is simple, a small ulcer, 2 by 2 centimeter ulcer over the limb, which has a lot of slough on it, and the patient was referred to me because they thought that this is a surgical case. So this does not require debridement. You can see that the margins are proper. They are just having some erythema. The rest of the skin appears to be absolutely normal. And one important history the patient gave was the patient had an episode of Melaena. So when the patient was actually checked for her GI tract, it was found out that the patient had something called as a Crohn's disease. So there is granulomatosis with polyangiitis. So this is granulomatosis with polyangiitis. It is a type of vasculitis which is associated with Crohn's disease. So the patient might have something underlying systemic pathology. So whenever you are going to see a solitary ulcer without any cause, so suspect some systemic disorder. So one systemic disorder you are going to suspect is some autoimmune disorder, which is a pyoderma gangrenosum. So you can typically see in the photo that the edges are absolutely normal. There is some erythema over the edges and margins. There is some slough in the ulcer. It is a non-healing ulcer. And always remember, there is no need for debridement. So no need for debridement. Do not debride because it is problem with the immunity. So you are going to do immunosuppression, steroids and cyclosporin, and then the patient is going to recover. What is purpura fulminans? So another case which was referred to me, patient was in sepsis. So now this is a vicious cycle. So medicine people are going to refer the case to you because they are going to think that it is the ulcer which causes sepsis. And also sepsis due to certain organisms can cause ulcer. So it is like, who came first? Did the hen appear first or the egg appeared first? So that is the time when you have to think that what is the exact type of ulcer. So now again see that what is purpura fulminans? The patient is having blood clotted type of ulcers all over the limb. But again you can see that there are absolutely normal patches of the skin in between. The skin between those two patches are absolutely normal. So whenever the skin is absolutely normal between the patches of the skin, it means that it is again might be related to some systemic pathology. So what happens is, in this type of the sepsis, what happens is there is disseminated intravascular coagulation. So what happens is, we saw that angiosome concept. So whenever the small angiosomes are going to be thrombosed, so whenever there are going to be small thrombosis of the vessels because of the disseminated intravascular coagulation, these small angiosomes are going to get thrombosed, and because of thrombosis of these, the patient is going to have necrosis of the skin, and that is nothing but a systemic sepsis which is causing ulceration. And treat the underlying cause. The patient needs to be started on anticoagulation, and later on, when the patient is going to recover, you can actually do skin grafting for the patient. But remember, the skin or the local pathology is not the cause of sepsis. It might be something related to the body which is causing this sepsis. So whenever a patient is going to come to you, first thing, is the patient a surgical patient or a medical patient? So rapid onset subdermal capillary thrombosis, and hence the patient is having hemorrhagic skin necrosis in symmetrical distribution. You know, necrotizing fasciitis, it is nothing but necrotizing soft tissue infection. So we already saw that in NSTI, in general surgery module. And what are the 3 tests which we are going to do? The first test is the finger probe test, which during the debridement, if the finger is easily slipping, it is called as a finger probe test. Then the second test we saw is going to be, yes, active fresh bleeding. Third important step we are going to saw is the frozen section. So whenever you are debriding a patient of necrotizing soft tissue infection, always remember that you are going to check for the healthy tissue, and you are going to remove all the devitalized tissue. So again, dishwasher fluid, no bleeding, and finger probe test positive, and mortality is almost 70% despite treatment. But here it requires surgery. So as you can see, there are ulcers on the limb, and also there is associated, between the ulcer there is associated skin cellulitis, skin erythema. So it is a forming necrotic patch. So in these patients you need debridement. So you should know which patients require emergency debridement and which is the medical cause. So these are the important things which you should be knowing. Then again, neurofibromatosis, there are multiple café spots. It is an important MCQ for NEET PG specifically. So you know that neurofibromatosis on chromosome 17 and F1 gene. This patient might also have multiple vestibular schwannomas. So café spots, Schwann cell tumors, and Liss nodules. And here you are going to just do the excision of symptomatic neurofibromas, and always do an ophthalmic examination because this patient might have optic neuromas as well. Then something called as a Gardner syndrome. So why is Gardner syndrome mentioned here? So whenever a patient presents to you with multiple lipoma, what is that disease called as, the patients who present with multiple lipoma? Anybody knows? So when a patient presents with multiple lipomatosis, the disease is called as, excellent, Dercum's disease. So whenever a patient is having multiple lipomatosis, always ask one history to the patient. Is the patient having PR bleed? Because whenever the patient has multiple lipoma, there is an important gene mutated, that is the APC gene mutation, which is associated with familial adenomatous polyposis, or it might be also associated with multiple sebaceous cysts. And these patients require colectomy, total colectomy. So any patient who comes with multiple lipomas over the skin, just ask one question in the negative history, that is there any association with colonic bleed or change in the bowel habitus? If so, the patient needs to undergo a colonoscopy. So you think that this might be just a lipoma, but it is because of the underlying APC gene mutation which causes multiple lipomas over the skin. Again, MCQ questions, Ferguson-Smith syndrome. So there might be a question that a young male is going to present with multiple small squamous cell carcinomas over the head and face region, and they disappear automatically. So it is nothing but a Ferguson-Smith syndrome and multiple self-healing squamous cell carcinomas. You don't need to operate any of the squamous cell carcinoma. Surgical excision is only important for the non-healing lesions. And again, dermat question, there is something called as nevus of Ota and nevus of Ito. So our face is like circular region. So how I used to remember is our face is circular in region. So O for circular, O is circle, and hence the nevus of Ota, it is the congenital nevus depigmentation. So when we saw the skin diagram, we saw that there are something called as melanocytes. So this is a melanocyte which is going to give the skin whatever color it has. So this is a melanocyte. So this melanocyte, whenever there is going to be a rapid proliferation of melanocytes, it is going to give rise to a nevus. So few babies are born with this nevus. It is called as nevus of Ota. O is means circular, it is a face, and it is present on the face. And whenever it is present on the back, so obviously if O is covered, then what is remaining? It is the Ito which is present on the back. So whenever there is going to be a nevus on the back, it is nothing but nevus of Ito. So it is again important point for the MCQ, and you have to monitor the lesion for malignant transformation. Which type of malignancy can this develop? So obviously it is melanocytic proliferation, so they are at risk of development of so it is a malignant melanoma. So whenever the patient is going to present with any type of nevus in the body, and if it is increasing in size rapidly, so we are going to suspect what is called as a melanoma. We are going to suspect what is called as a melanoma. So now we are going to talk about the skin tumors. So we are going to start talking about the skin tumors. So always remember one thing. So whenever you are going to encounter a patient of skin lesion, any patient of skin lesion, you are going to actually think about 5 things: A, B, C, D, E. So first ABCD which we saw was in the trauma chapter. So control of hemorrhage, then airway, breathing, circulation, disability, exposure. Now we are going to talk about another important thing which is going to be A, B, C, D, E for the skin lesions. So A, B, C, D and E for the skin lesions. So if these things are going to be present in a skin lesion, then that is the time you are going to suspect that there might be some underlying problem in the skin, not a normal pathology or not a benign pathology, and I might need to go for a biopsy. So what is A? So A is nothing but the first thing which you are going to see is going to be the asymmetry. So asymmetrical lesion, if a region is not perfectly round, it is not asymmetrical. So if it is asymmetrical, then the first thing you are going to suspect, okay, this might be a malignancy. Then what is the B? So border irregularity. The third important thing is color irregularity or color change. The fourth important thing is going to be the diameter or dimensions. So usually they found out that more than 5 to 6 mm of any lesion is going to be something pathological and not normal, and E is going to be enlargement. So rapid enlargement of any lesion, always suspect some pathology. It might not be a malignancy, but you have to suspect some pathology. So what are the type of skin lesions? So whenever you are going to encounter any skin lesion, ask these 5 things: A, B, C, D, E. If these things are looking positive, then you might need to further investigate the patient, or there are high chances that the disease is going to be benign. So what happens is, you know that we have already seen the diagram of the skin. So this is the diagram of the skin. So what happens is, because of chronic sun exposure, I told you already that UV rays are more prominent to cause melanoma and basal cell carcinoma, and ionic radiations are going to cause squamous cell carcinoma. But obviously a squamous cell carcinoma is very aggressive tumor, and it is again non-specific. So the ionizing radiations as well as the UV radiations can cause a squamous cell carcinoma as well. So squamous cell carcinoma can be caused because of any type of radiation, and malignant melanoma and basal cell carcinoma are predominantly caused because of UV radiation. So now when you are actually seeing, because of the chronic exposure to the sun or radiation, what is going to happen? So these cells, these keratinocytes which are going to be present, these keratinocytes are going to develop into something called as a haphazard arrangement. So why is this haphazard arrangement going to happen? It might be because of the DNA damage. Because of the chronic DNA damage to the cell, there is going to be a haphazard arrangement, and the patient is going to present to you with something called as a non-specific erythema or non-specific skin lesion. And this skin lesion is going to be called this skin lesion is going to be called as actinic keratosis. So what did I say? some part of the cells are not behaving properly, they are undergoing some rapid proliferation, or they are going to be arranged in a haphazard manner, and the presentation of the patient is going to be something like this. So patient is going to have something called as, see, this is the lesion, so this is typically on the nose. So if you are going to see, the patient will have some red patch. That patch is not going to go off on its own. That patch is going to be remained for 2 weeks, 3 weeks, and then the patient is going to come to you, because these small types of insect bites, these small types of irritation, eczema is going to go back on its own within 1 week. The patient is going to go to some local chemist, he is going to give him some topical steroid application, it is going to go off. But if this patch doesn't go, he is going to come to you. So always remember that when a patient is coming to you, it means that it is severe. No patient is going to come to you on the first day with some small lesion on the skin, just check it out, I don't feel it's normal, unless until the patient is very well read. So what happens is, a small segment of haphazard arrangement of the keratinocytes or proliferation of the keratinocytes, it is going to cause something which is called as an actinic keratosis, which is going to be a pre-malignant lesion. It is going to be a pre-malignant lesion. Then what is going to happen? Then these keratinocytes are going to, this will be contagious. So it is going to spread all across the 5 layers of the skin. So this, what I am showing, is going to spread across all the 5 layers of the skin, but it is not going to invade the basement membrane. So the basement membrane is going to be intact, and that is when I am going to call it as carcinoma in situ. So when all the layers of the skin except the basement membrane is going to be involved, I am going to call it as carcinoma in situ, which is called as there is going to be dysplasia. The cells are going to be haphazardly arranged, but it does not penetrate the basement membrane. So it is nothing but carcinoma in situ, which is called as Bowen's disease. And when it is going to penetrate, when it is going to actually penetrate the basement membrane, then we are going to call it as a squamous cell cancer. So before happening of the squamous cell cancer, what important things do you need to know? So the one important thing is that initially the patient is going to present with something called as a pre-malignant lesion like actinic keratosis. Then the patient is going to have Bowen's disease, and then the patient is going to have squamous cell carcinoma. But in when the patient is only and only exposed to radiation. If the patient has oral squamous cell carcinoma, it is not because of radiation, it is going to be because of other factors like chronic tobacco chewing, alcohol intake, ill-fitting dentures. So that is not because of radiation. So when there is radiation problem, radiation exposure, might be UV radiations or might be because of ionizing radiations, this is going to be the sequence of formation of squamous cell cancer. So as we saw, this is going to be your actinic keratosis, very ill-defined patch which is going to be there, and then it is going to form the squamous cell carcinoma. So initially this, then it forms the Bowen's disease, and Bowen's disease is going to give rise to squamous cell cancer. So in between this love triangle, there is a fourth component which is called as a keratoacanthoma. So what is keratoacanthoma? Sir, एक्चुअली देखने में तो ये ज्यादा ही डेंजर लग रहा है स्क्वैमस सेल कैंसर से, बट स्क्वैमस सेल कैंसर हैज ऑलरेडी ब्रीच्ड द बेसमेंट मेम्ब्रेन दोस्तों, एंड दिस केराटोएकेंथोमा इज द सेम लाइक स्क्वैमस सेल कैंसर. इट हैज अ नोड्यूल ऑन द टॉप, बट इट इज actually not invaded the basement membrane, and the cells are not dysplastic. So the cells are multiplied. There are large number of cells. So there is hyperplasia, but there is no dysplasia. So hyperplastic cells, but no dysplasia. But अगर देखा तो it is almost looking the same. The squamous cell cancer and the keratoacanthoma actually look the same. Hence, any keratoacanthoma, any type of a nodular lesion on the skin, you are going to go for excision, considering that it is malignancy. Even if you are going to take the biopsy is going to tell you that there are multiple cells of squamous cell. They are keratinizing. They are having haphazard structure. They are multiplication more in number. But in keratoacanthoma, they will say that it is well differentiated because all the cells are absolutely normal. But even we have something called as a well differentiated squamous cell carcinoma. So in cases of well differentiated squamous cell carcinoma, that also can present the same way. So any lesion which you are going to encounter, you are going to do excision, wide local excision. How to do a wide local excision, we are going to see after some time. So now we'll go down to the lesions. So actinic keratosis, again as I said, it is because of solar radiation, scaly rough patch on the sun damaged skin. It causes dysplasia, but only the dysplasia is at some portion, and it will progress to SCC if it is not accompanied with sun protection. Hence you know that the cricketers are going to apply the sun protection cream. They don't apply that sunscreen lotion. It has some UV penetrance. You know that it is UV 40, UV 50. Why? Because it is going to prevent the UV rays to penetrate into the skin. So they don't do it for putting a fancy thing, or oh god, they are not looking so what do you say, they are not looking so nice, so they are putting the cream. It is because to protect them. They have doctors and physiotherapists and many other people in their team, and that is the reason these people are going to be protected from these things. What are you going to do? A topical 5-FU cream is important, or a diclofenac gel over the lesion, because it is again inflammatory. It can just, or applying sun protection, it is going to help it out. Then comes the Bowen's disease. Whenever the full thickness epidermal dysplasia, so when actinic keratosis is only partial thickness, so whenever it is going to convert into full thickness, we are going to name it as Bowen's disease. But it is a true cancer, because now it has invaded all the 4 layers and it is now progressing into squamous cell, invasive squamous cell carcinoma. And here you are going to apply again topical 5-FU cream or photodynamic therapy. And if it is not responding to this cream, then you can go for excision. Keratoacanthoma, it is a rapidly growing dome-shaped nodule, but it is typically considered as well differentiated, and hence it is always limited. It is not going to breach the basement membrane, but excision is always done because nobody wants to take a chance. Because I am going to tell you that squamous cell carcinoma, the SCC, the most important prognostic factor is going to be the depth of the lesion. More the depth of the lesion, the patient is going to have more mortality and morbidity. So in squamous cell carcinoma, the prognostic indicator is always the depth of the lesion. So whenever you are in doubt, just excise it. Whenever you are in doubt, excise it. And what is melanocytic nevus? We know that it is nothing but mole. It is benign melanocytic proliferation. So in Marathi, which we call as til, and in Hindi what we call as til. So it is nothing but a mole which is going to be present on you anywhere on your body, but there is a small risk of transformation into a melanoma, especially in the dysplastic nevus syndrome. So few people are going to be born with a congenital condition called as a dysplastic nevus syndrome, multiple nevus on the body, and these people are more prone for developing malignancy. So excise it if it is going to increase rapidly. So don't think twice, because malignant melanoma, it is highly invasive and penetrative. So whenever it is going to invade and penetrate, it is going to metastasize very early, and the patient are going to have a very poor life. So whenever a patient comes to you with sudden enlarging size of the nevus, just excise it. Don't keep it. So what did we say? The progression of pathway, the actinic keratosis is going to progress to Bowen's disease, and then it is going to progress to invasive cancer. And each step requires escalating treatment. So first we are going to apply a 5-fluoro or imiquimod cream. Then we are going to step up for excision, and still not going. Then if it goes to SCC, then it requires a radical resection. And actinic keratosis is treated with moisturizer alone, but still some will progress. So very important. Now coming to the first malignancy, that is your basal cell carcinoma. So the most important cancer and most common skin cancer worldwide is your squamous cell carcinoma. And again, as I said, it is because of UVB induced, no ionizing radiation here. So ionizing radiation specifically for SCC. Always remember, ionizing radiation only SCC. Arises from the basal cells of the epidermis. We already saw the diagram. It is going to arise from the most basal cell. So this is the cell which is going to give rise to BCC. So this is important factor here. And then the classical site is going to be head and neck. Wherever the patient is going to be sun exposed, so this is going to be the face of the patient, this is going to be the lips, and this is going to be the head. So typically the patient is going to have these lesions above the nose, so where the nose ends. So typically you are going to see the lesions here. So this is going to be the typical lesion. So on the head and neck, face, nose, periorbital region, but never over palms or soles, because palms and soles actually don't get sun exposed. So you are always having the hand pronated or in the fist closed position. You are walking on the ground, sun is not exposed. So it is not, almost never seen on palms and soles. So if you find a lesion in palms and soles, tag me and also put me in your publication, so we all will become famous together. So BCC is very rare on palms and soles. So again, some important parts for MCQs, it is important, might not be required for your actual clinical practice, but importance is to diagnose. So you can see here, how is BCC seen? So a typical crusting lesion, there is some amount of necrosis in the center, and it is going to be surrounded by a normal tissue or the hyperemic tissue. So this is nothing but basal cell carcinoma. It is marked by a marker here, but this is going to be your basal cell carcinoma. So these are the types of the basal cell carcinoma. So one important thing which is to take home, that basal cell carcinoma most common type. Basal cell carcinoma most common type is the nodular type. Basal cell carcinoma is the nodular type. Most common. So it appears like a nodule and it is very slow growing and has best prognosis, or it has very good prognosis. It has very good prognosis. But when it comes to malignant melanoma, the most common type, when it comes to malignant melanoma, the most common type is superficial spreading, which is again, nature is good, nature is kind. So most common type of malignancy which is going to be seen, it is going to have best prognosis. But the nodular type of malignant melanoma is going to have worst prognosis. So in basal cell carcinoma, nodular is most common and it is very good prognosis. But when nodular type comes in malignant melanoma, it has the worst prognosis and it is again less common. The most common in malignant melanoma is going to be the superficial spreading type. So I hope it is clear. So just go through the chart, we'll talk it out. So nodular is most common, pearly rolled out edges and telangiectasias with central ulcer, slow growing, locally destructive, and it is commonest overall. Good prognosis. Superficial, it is less invasive and it can be treated topically. So whenever the basal cell carcinoma is going to be presented to you, you can actually treat it. So we are going to draw a small table which is going to give you a more high yield output. So again, it is a morphic or the sclerosing type. So whenever it is going to be associated with an enzyme which is called as a collagenase, so it is going to cause the destruction of the local tissue and it is going to spread rapidly. So whenever there is a sclerosing type of the variant, which is also called as a morphic type of variant, it is going to have a worst prognosis. And pigmented type of it is heavily pigmented. So this type which is seen, it is kind of a heavily pigmented and it is again like a standard BCC, just that there is more pigmentation. And basosquamous, so it is a type of basal cell plus squamous cell cancer. So type of it is less differentiation, so it is again highly aggressive. It is going to be highly aggressive. So we are going to go down and we are going to check how are we going to manage the patient. But before that, let's see what are the high risk features. So whenever a patient is going to present to you, you are going to take the biopsy of the lesion. So what are the types of biopsy we know? So there are three types of biopsies. One is the punch biopsy. Punch biopsy means there is a biopsy needle which is going to fire. So whenever you are taking a biopsy from inside the body cavity within the breast, so what do? You are going to insert that needle into the breast and it is going to fire the tissue. So it is called as a punch biopsy. The second important biopsy is the incisional biopsy. So whenever you are going to remove, so this is going to be your lesion on the skin. And this is going to be the normal surrounding skin. So you remove one part of the malignant lesion and other part of the normal tissue. So this biopsy is when you are removing one part of the malignancy to check, it is incisional biopsy. And whenever you are going to actually remove the whole tumor, whenever you are going to remove actually the whole tumor for a biopsy purpose, it is going to be an excisional biopsy. Another important recent advance is a liquid biopsy. So what is liquid biopsy? Where in the blood, the DNA of these malignancies can be seen in the blood. So it can be picked up from the blood or the vessel surrounding the lesion. So if you have a lesion in your right arm, you can take the blood from the vein of this arm and you can check for the malignant cells. And you can actually find out the malignant cell DNA in it, and that can tell you which type of cancer it is. So it is called as a liquid biopsy. Upcoming new recent advance, not yet included in the textbook, but soon will be in the textbook when the meta-analysis or the level 1 evidence are available. So how are you going to classify this lesion if it is a high risk or low risk? So whenever this type of patient is going to come to you, first apply the rule of A, B, C, D, E. So in that A, B, C, D, E asymmetry, then you are seeing the borders, then you are seeing all those 5 parameters. You seeing that this lesion is not actually very good, it has some malignant potential, so you are going to take a biopsy. So how do you take a biopsy? So over the face, usually you are going to take an incisional biopsy, because if it is a benign lesion, if it can be treated with some topical ointments or conservative therapy, you are not going to remove this much area of the face, and if you are going to not remove, it is going to be cosmetically better. So always remember, on face, you are going to always take incisional biopsy. So face, always go for incisional biopsy. Or elsewhere, you can go for excisional biopsy. So at least for the malignancies, you can go for excisional biopsy, and in the same setting, you can wait for the frozen section. So what is frozen section? So that pathologist is going to get that tissue, he is going to chop it out, he is going to see what type of malignancy it is, and he is going to call you. Boss, this is this type of malignancy. I don't think it is invasive, so you can just stop the surgery. So you can stop it there and you can close the wound. But if he is going to say, oh bro, it is not something which is benign, it is a malignant tissue, then he has to tell me what type of. So whenever a frozen section is given, you are going to ask for, importantly, first thing you are going to ask for is going to be type of malignancy. The second thing you are going to ask for is differentiation. And third important thing you are going to ask for is the margins. So now when I'm going to send this excisional biopsy for a frozen, the pathologist is going to tell me, sir, it is looking like a squamous cell cancer, and the margins which you have sent. So what are the margins? So one margin is going to be the circumferential margin, and the other margin is going to be the depth of the malignancy. So all the margins are free of tumor. So yes, it is good. Then your excision is almost complete. Then you can close the wound. So margins, type of malignancy, and differentiation of malignancy. So on what basis the pathologist is going to tell you if the patient has high risk features? So how are you going to check if the patient is going to have high risk features? So if size is more than 2 centimeters, if it is directly involving any bone, so if it is present over your cheek and it is directly fixed with the underlying zygomatic bone, so it is a high risk feature. If the patient is on immunosuppression, so we are going to talk about transplant related malignancies. So there is something called as transplant related lymphoproliferative disorders. So you are going to talk about them when we are going to study the liver transplant or organ transplant. So whenever the patient is immunocompromised, there is going to be malignancy. We are going to talk about it shortly when we are going to discuss the multiple melanoma. How does immune system play a role in malignancy? If it is again morphic, which is a sclerosing variety, or it is a squamous type of variety, if it has perineural or perivascular invasion. So we know that the malignancy typically is going to travel along the blood or lymphatics, but some malignancies also travel around the nerves, and if there is nervous involvement, then that is the time it is considered to be a perineural involvement. That is called as a perineural or perivascular involvement. So it is going to be a high risk feature. So how are we going to actually plan the surgery? So let's jot it down. So whenever a patient is going to come to you with ABCDE lesion, so ABCDE, anything of it is positive, you are going to prefer a biopsy. Either it can be incisional or excisional. So if the biopsy is going to tell you about BCC, so this protocol is going to be same for all type of malignancies. Any skin malignancy, protocol is the same. But now the pathologist is telling me, sir, it is BCC. So what is the type of BCC it is going to be tell? So first check for high risk features. So first you are going to check for high risk features. If present, then what? And if high risk features are absent. So if the high risk features are absent, you can go for a wide local excision with 4 mm margin. And it is sufficient. You don't need to do anything. So this is going to actually suffice the patient for his whole lifetime. But if the patient is having high risk features, then we are going to actually go for what is called as a Mohs micrographic surgery. So what is Mohs micrographic surgery? So pathologist is also at work, surgeon is also at work. So first what you do, you are going to send this much amount of tissue. Pathologist is going to say, sir, involved. Okay, buddy, no problem. Another tissue is you are going to send. Sir, involved. Okay, buddy, no problem. More excision. Sir, involved. So you are going to go on increasing the circumferential margin or the depth of the margin, whatever the pathologist is going to tell you. Because what happens is, in the sclerosing type of the variety, it is going to spread laterally. It is going to be scar-like, and so it will be indurated. So it is going to spread to a lot of the tissues. So you don't know exactly what is the normal margin. So you are going to contact the pathologist. Oh, buddy, just tell me, is it normal or is it abnormal? Sir, involved. Go for more excision. Sir, involved. Go for more excision. So that is the type of what is called as a Mohs micrographic surgery, and typically done in high risk variants or recurrent variants. It is also now utilized for low risk variants on the face. Because what happens is, on face you need to be conservative. On face, again, as I told you, never an excisional biopsy, always an incisional biopsy on the face. Similarly, if there is going to be a low risk region on the face, just try to remove whatever actually is very small involved. So if this ulcer might be present on the, so let's consider that this ulcer, if it is present on the limb, I might excise this much amount of tissue. But if it is on the face, I will prefer excising only this much amount of the tissue, and again ask the pathologist, sir, is it positive? Yes, it is positive. Then again excise the tissue. So that is called as a Mohs micrographic surgery, and you are going to send multiple biopsies to the patient. And then comes, so as I told you, if it is if high risk features are negative, it is a low risk lesion, wide local excision with 4 cm margin. Here you are going to prefer Mohs micrographic surgery. And along with that, you can plan adjuvant therapy. And a third variety where, as we saw, that if it is going to be a superficial spreading type, so it can just be tackled with topical application of creams. So if it is superficial spreading type, you can apply some topical creams. So topical creams you can apply like topical 5-fluorouracil imiquimod cream, the same cream which we are applying for your actinic keratosis. So you should know these things when you are going to treat a patient with basal cell carcinoma. So this is a very important flowchart. It is important for dermatology, important for plastic surgery, important for general surgery, for NEET PG, for your final exams. So anywhere the basal cell carcinoma when it is going to come, this is the short note which you are going to, or this is the long answer even which you can going to write. So ionizing radiations cause SCC but not basal cell carcinoma, and UV radiation cause all types of cancers, and follow-up is only required for high-risk BCC. So as I said, wide local excision done, send the patient home, no need for follow-up. So it is very much important for us to know all of it. So radiation therapy very rarely indicated when the patient is very much elderly and surgery cannot be tolerated by the patient, but it has a secondary risk for SCC. That's what I told you, that radiation causes squamous cell carcinoma. So when you are going to give radiation for BCC, the patient might develop squamous cell carcinoma later on. And this is a drug which is vismodegib. It is a monoclonal antibody. It is typically used in advanced and metastatic BCC, and it is going to basically act on the pathway of cell multiplication. So we are going to talk about them later when the drugs are going to be discussed in other malignancies. Point of telling you is that only chemotherapy approved drug is going to be the vismodegib. So whenever it is going to come, the question might come to you that chemotherapy is indicated in dash type of cancer. So only advanced and metastatic type of basal cell cancer we are going to give this type of chemotherapy. I hope it is clear to you. Now we are going to jump off to the second malignancy, which is going to be a squamous cell cancer. So whenever we are going to talk about the squamous cell cancer, always it is important that it can be caused because of ionizing radiations and the UVB radiations as well. So it can be caused because of both. So as we saw the photo rightly in the first thing, so this is nothing but a squamous cell cancer in the gluteal region. So see how fungating lesion it is going to be presenting with. And so what happens in the squamous cell cancer? It is the second most common type of malignancy. First is basal cell carcinoma, chronic UV exposure, ionizing radiations, and HPV, specifically HPV 16 and 18. So again, there will be multiple warts on the skin lesion which might get later on convert to malignancy, and that is the reason to prevent against warts. Nowadays they are doing a meta-analysis that even the HPV vaccines can be given to all the patients as a national immunization schedule. So when you are going to inculcate, the warts are going to reduce, and anti-HPV vaccine, when you are going to give it to the patients, naturally the squamous cell carcinoma incidence might reduce. So there might be a preventive strategy for development of a squamous cell cancer. So it is something which is coming. Again, immunosuppression, or it might be an arsenic exposure, which is an occupational hazard. So always remember, as we talked about the lesions, in high risk lesions in basal cell carcinoma, similarly we are going to talk about lesions in squamous cell carcinoma. So there we talked about the size 2 cm, here the size is 2 cm. The depth of invasion, as I told you that the depth of invasion is the most important prognostic factor. So highlight it, put it on your walls, put it on your notebook, put it as your wallpaper. The depth of invasion is the most important prognostic factor. So more the depth of invasion, if it is more than 4 mm or less than 2 mm, so good or bad prognostic factors. Histological grading, so it is also called as something called as a Broders grading. So Broders grading, we saw that very well differentiated SCC is can resemble keratoacanthoma. So again revision. So keratoacanthoma can be resembled by a very well differentiated SCC. Again, the Broders grading will differentiate between the poorly differentiated and well differentiated. Location, so whenever it is going to be present on the lip, ear, temple or non-sun exposed region, it is because of ionizing radiations, and ionizing radiations are worse than UV radiations. So sun exposed body skin, that SCC is going to have a better prognosis. Perineural invasion is present, perivascular invasion or lymphovascular invasion present, and it is going to be a bad prognostic factor. And host, if the patient is immunocompromised host post transplant malignancy, it is going to have a worse prognosis. So similarly, if it is absent and patient is immunocompetent, the prognosis is going to be good. So always remember, for squamous cell carcinoma anywhere in the body, the most important thing is excision, excision and excision. excision, excision and excision, except it is not feasible. For example, if nasopharyngeal cancer, you cannot remove nasopharynx, it is not possible. Oropharyngeal cancer, you cannot remove oropharynx, so that time you can give radiation. Laryngeal malignancy, laryngeal squamous cell cancer, so you need to preserve voice of the patient, you need to check for the morbidity of the patient. The surgery should not cause the death of the patient itself. So whenever the patient is having a resectable disease, the part of the body is resectable, resection is the only key. As we saw in the basal cell carcinoma, superficial type, you can treat it with creams. There is nothing called as cream here. It is always excision, excision and excision. So low risk lesion. So we divided the SCC into low risk and high risk. So low risk lesion 4 mm margin, same as BCC. So if you remember basal cell carcinoma, the margins are 4 mm if the patient is having well differentiated or low risk lesion. But in high risk region, there we are going to do a Mohs micrographic surgery. Here you are going to place a 1 centimeter margin. So whenever a high risk lesion is present, go for a 1 centimeter margin, and if low risk region is present, you can go for a 4 mm margin. And whenever you feel that it is depth, so a simple thing which you are going to keep it in the mind. So whenever the underlying muscle, typically on the face, when platysma is involved, that is the time you have to actually go for wide local excision. But if the muscle is not involved, only the dermis and subdermal tissue is involved, you can just go for the wide local excision of the skin. But whenever the muscle is involved, then you need to go for the whole chunk of the tissue. So whole tissue needs to be removed. So it is very much important. And in squamous cell carcinoma, sentinel lymph node biopsy can be considered. So what is sentinel lymph node biopsy? So these two things, the immunity and the immunomodulation, and the sentinel lymph node biopsy, I'll talk at the concluding type of the lecture. So whenever a nodal dissection is present, so as I said, squamous cell carcinoma, resection, resection, resection. So if it is going to be a lymph node positive disease, go for the lymph node dissection. So lower limb squamous cell carcinoma, go for inguinal block dissection. Head and neck malignancy, squamous cell carcinoma, go for you will go for the cervical lymph node dissection. Whenever arm squamous cell carcinoma, you are going to go for axillary lymph node dissection. So wherever the lymph nodes are draining, you are going to go for excision or the removal of those lymph nodes as well. So simple thing for squamous cell carcinoma: high risk features, low risk features. Low risk patients, and this is all topology. Same thing, if any lymphovascular invasion is present in any tumor of the body, it is high risk. If perineural invasion is present in any part of the body, it is again high risk. Any immunocompromised patient, it is high risk. So we are going to repeat these things again and again when we are going to see other malignancies. Point of view telling is, you should know which is low risk and which is high risk. High risk 1 centimeter margin, low risk 4 mm margin. Lymph nodes positive, go for resection. Sir, basal cell carcinoma lymph nodes, basal cell carcinoma is not erosive. It does not erode the basement membrane, or it does not metastasize. So basal cell carcinoma metastasis is rarely found. So no role of lymph node dissection in basal cell carcinoma. Hope it is very much clear. Now coming to the third and most important tumor, that is malignant melanoma. Wikipedia, photo from Wikipedia, all credits to Wikipedia. So we are not having any financial benefit out of it. So Wikipedia photo, same to same photo comes in your NEET PG exams. So whatever exams questions I have seen, the same photo is displayed on your NEET PG paper. What is this tumor? So it is nothing but a pigmented nevus. So all types of things can be seen. So first you can see is going to be the asymmetry. Nowhere it is symmetrical. The borders, you can see the borders are irregular. The color is different here. The color is different here. So did you see all of it? So all the things are seeing, so if the diameter you can see looks like more than 6 mm diameter, and also you can see that it might be enlarging based on the patient symptoms. So all risk factors are present here. So it means that it is some pathology. So typical photo of where you can see that this lesion is not very much characteristic of benign etiology. So it is less prevalent. So malignant melanoma is very less prevalent, but it is more lethal. So as I said, it is very deadly disease and accounts for 75% of skin cancer deaths. So 2 malignancies account for 25% deaths, and this one malignancy is going to account for 75% deaths of the patient. That's how lethal this disease is going to be. Increasing rapidly. Why? More amount of UV radiation, more melanocytic proliferation, and more mutations. So it is typically seen in the fair skin population with high UV exposure, and vitamin D might be protective against this. So the studies are still going on. We are not sure about this. So again, what are the types of disease? So this is not very important. Basal cell carcinoma types are important because we saw that there is a sclerosing variation which is very high risk and which needs what do you say, radical type of surgery or Mohs micrographic surgery. But here the types are not important. At least you should know that superficial spreading type is the most common and it has multiple colors. So this typically looks like a superficial spreading type of the lesion, and it grows horizontally than vertically. And that is the reason this might not be a very high risk lesion, and it has good prognosis. It has the best prognosis. And the second lesion is the nodular melanoma, and it is a nodule, so it is popping out on the skin. Similarly, it might be going deep into the skin. So it is raised dark nodule and no pre-existing nevus. So typically these superficial spreading type develop from the existing moles. So existing mole, if it is present, the malignancy which is going to be formed from this lesion is going to be a superficial spreading type of melanoma, and sudden appearing a new onset nodule which looks like a mole but is growing rapidly. This is a nodular melanoma and has vertical growth, and it has a highest malignant potential and worst prognosis, and this typically goes for lymph nodes. It is going to metastasize to the lymph nodes. Sir, most important prognostic factor of squamous cell carcinoma. Excellent, it is going to be your depth of invasion. But here the most common prognostic factor, the most important prognostic factor is the lymph node involvement. So it is going to be the single most important prognostic factor for the patient survival. So lymph node involvement if present, it is going to be lethal disease always and always. Sir, lentigo maligna type, the acral type, and a melanotic melanoma. So lentigo maligna, it is elderly people, skin damaged skins, and again it has the best prognosis. Not important to know. Acral means, as given, acral means palms and soles. So whenever it is going to be palms and soles, often it resembles the fungal infection, but later on you are going to find out that this is going to be a malignant melanoma. So you can see the four types. Superficial spreading type, most common. Nodular melanoma, it also is going to go deep. Acral is going to be on the palms and soles, and lentigo maligna, it is going to be brown and it become raised or change in color. So it is less common, seen in elderly. So at least one part, if you know, if you can rectify, it is fine. But most important thing is don't miss out on superficial spreading type and nodular type. It is very much important. Most important thing here is we saw that stratum granulosum, the layer which is going to be present, from that layer you are going to measure the depth of the malignancy. So here the stratum granulosum is going to be present. From stratum granulosum the depth of the invasion is going to be present, and that depth of invasion is going to actually give you an indicator which is called as a Breslau's index. So what is Breslau's index? So whenever the depth of invasion increases, your wide local excision margin is going to increase. So what is the basic funda for the Breslau's index? So whenever the depth of invasion, what is important? So whenever the depth of invasion is going to be less than 1 centimeter, you can just go for something called as a margin of 5 mm. You can go for a margin, wide local margin and depth margin of 5 mm. When the depth of invasion, so when the depth of invasion is going to be 1 to 2 centimeters, you are going to go for almost 1 to 2 centimeter margin. And whenever the depth of invasion is going to be more than, this is mm. So when the depth of invasion is going to be less than 1 mm, you are going to go for 5 mm margin. 1 to 2 mm is you are going to go for 1 to 2 centimeter wide local excision, and more than 2 mm depth of invasion you are going to go for 4 centimeter margin. So very important to know. We are going to talk about Breslau's skin grading here. So if the depth of invasion is less than 1 mm, you should go for a 1 centimeter margin. If it is 1 to 2 mm, you should go for a 2 centimeter margin. And if it is 2 to 4 mm, you need to go for 2 to 4 centimeter margin. So that is nothing but T1, T2 and T3 lesion. And obviously if it is going to be, it is going to be more deep, more than 4 mm large, then the granular layer, it is going to be a T4 disease. So T4 disease is not important here. Most important point is the depth of invasion is important. So more the depth of invasion, 1 mm, 1 to 2 mm, more than 2 mm. The margins, the excision margins are going to change from, excellent, from 1 centimeter to 2 centimeter to almost to say 2 to 4 centimeters. So that is very much take home message you are going to take from the malignant melanoma, that the Breslau's skin index is something about the depth of invasion, and it is measured always it is measured from granular layer. So it is going to measure from the granular layer of the epidermis. Sir, what does it tell me? Why is this point important? So whenever you are going to take a shave biopsy, What is the shave biopsy? It is again a type of incisional biopsy wherein you are going to scrub or you are going to just peel off the superficial layer of the skin, and those cells you are going to send for histopathology. So remember, if you are going to take the granular cells along with you, then the Breslau skin index, the margin is going to differ, and that time your wide local excision margins are going to change. Hence, never go for a shave biopsy. Never go for a shave biopsy. Never do a shave biopsy. It destroys the measurement. And never do a wide local excision as a diagnostic biopsy here, because if you are going to do a wide local excision, you are going to not map the sentinel lymph nodes. So always remember, in this lesion a sentinel lymph node biopsy is very much important, because we saw that we are going to check for the lymph nodes. If lymph nodes are present, patient is going to have worst prognosis. But now if you are going to remove the lesion straight away, if the lesion is removed straight away, you don't know the lymph node status prior hand. So always remember that in this typical melanoma, a sentinel lymph node biopsy always has to be done along with the excisional biopsy. No doing of shave biopsy, but in face you can still go for incisional biopsy. So that is very important. On face you can go for an incisional biopsy. Rest all the places you will go for an excisional biopsy, but with sentinel lymph node dissection. So what is sentinel lymph node dissection? So whenever the thickness is more than 1 mm, lymph nodes are almost involved. So if the depth is more than 1 mm, the lymph nodes are most of the times involved, and that is the time when you should go for a sentinel lymph node biopsy. So what is SLNB? I am just going to talk about it 2 minutes, and then we are going to conclude the chapter. So as I said, lymph node metastasis is the single most prognostic marker. So if the lymph node metastases are present, it means that the patient is going to have a very cumbersome process, and the patient might land up into the death. So let's see how the melanoma is going to progress. So when the melanoma is going to, how is the melanoma going to progress? So there is a proto-oncogene which is called as a BRAF inhibitor. So it is called as a BRAF gene. So whenever the BRAF gene is stimulated, it is going to increase the proliferation of the cells. So what did they found is, they found that there is a drug which is going to inhibit this BRAF, which is called as vermurafenib or darbafinib, which is a BRAF inhibitor, and it is useful in the stage 3 and stage 4. So Breslau stage 3 and stage 4 disease, this drug can be given to reduce the recurrence and also to increase the survival of the patient. But what they found out later on was, BRAF is not the direct pathway. So BRAF directly doesn't cause proliferation. It is going to first stimulate which molecule? It is going to stimulate a molecule which is called as MEK molecule, which is going to cause proliferation. So what you used to do, initially they found out that BRAF is stimulating proliferation. Block the BRAF, this pathway is blocked, and everything is fit and fine. But now they found out that, oh, the cell is now found out some other pathway, which is the MEK pathway. So they have now also blocked the MEK pathway. So BRAF and MEK inhibitors, they are given together, combined together to reduce the resistance. So cells are very smart. If you block the BRAF, it activated MEK pathway. If ये रास्ते से नहीं जा सकते तो उस रास्ते से जाएंगे, तो दोनों रास्ते block कर दो, so cell proliferation is going to reduce. So these are the drugs which are going to be given in all the cases. Why is this important? Because most of the patients of melanoma are going to present to you with advanced disease, because it is going to be rapidly proliferative, worse prognosis, more mortality. You need to know these drugs. In basal cell carcinoma, I told you it might not be absolutely essential, but you need to know these inhibitors when you are going to talk about malignant melanoma. So two things we are going to talk. What is SLNB? So what happens is, whenever a patient is having a malignancy, it is going to drain into some lymph node. So there might be a group of 30 to 40 lymph nodes. So when you are going to remove all the lymph nodes, it is called as a radical lymph node dissection. Radical LND. But if, what happens is, if this is the lesion and there are 40 lymph nodes in the neck, arbitrary number 40 lymph nodes. So if this lesion is going to drain into only 2 or 3 of them, why do I need to remove everything? So whenever you are going to, what happens is, whenever you are going to inject some dye along this lesion, the lymphatics draining from this lesion will highlight the lymph nodes where they are draining. So what do? I am going to inject some dye which might be intradermal. So which are the 2 dyes you are going to inject intradermal? So one dye is going to be a radio dye, which is a technetium 99 sulfur dye, or the other dye might be brilliant blue. So it is nothing but type of a methylene blue. The dye which is almost like a methylene blue, it is also called as vital blue. It is also called as vital blue. So whenever you are going to inject that dye in the dermis region, the region which is drained by the lymph nodes which are going to drain this lesion, they are going to be highlighted. So you are going to first inject the dye then you are going to remove the lesion, and then you are actually going to scan the gamma probe. So there is a probe which is present. So you place the probe over this region. Oh, this lymph node is highlighting. So this lymph node is picking up the gamma activity. Or you take a small incision and you are going to see a blue colored lymph node. So you are going to cherry pick these lymph nodes. So, and you are going to send this for SLNB. So this is nothing but sentinel lymph node biopsy. And if it is positive, then you need to do a radical neck dissection. Because radical neck dissection adds to mortality and morbidity of the patient, you are going to inject the dye in the intradermal lesion, check where the lymph nodes are getting enhanced, pick up those lymph nodes. So ideally they say 3 to 5 lymph nodes are essential, and then if those are negative, you can conclude that there is no nodal disease and you can refer the patient. You can close the patient as it is. But if any of the lymph node turns out to be positive, then you need to proceed with the whole lymph node dissection. So SLNB can be done where? It can be done in the squamous cell carcinoma. It was initially done by Cabana in the penile cancers. So we are going to talk about it in the penile cancer. So it was initiated by Cabana surgeon in the penile cancer. Now it is also done for breast cancer routinely. So you are going to, this is about the SLNB. So what is about, so what is something which is called as immunotherapy? What is immunotherapy? So we have talked about it in the general surgery and malignancy module as well. What happens is, this is going to be your malignancy cell. So let's consider there are some terrorists which are now actually sitting in the train. So we know that these terrorists are to be removed from the train, but whenever the ticket checker is going to come, they are going to have the fake tickets that we are normal people. So what are those 2 fake tickets which the cell are going to carry? They are going to carry molecule which is called as PDL1 molecule. So this molecule is called as a PDL1 molecule, which is going to be present on the cancer cells. And second molecule which we are going to see, the second molecule is going to be CTLA4. The second molecule is CTLA4. So what is going to happen whenever the ticket checker, so who is the ticket checker? T for ticket checker, T for T cells. So whenever T lymphocyte is going to come, he is going to see, अरे इसके पास तो ticket है अपने body का, चलो आगे चलो, अरे इसके पास तो ticket है body का, but is this ticket valid? It is invalid and fake ticket. It is a fake ID. It is the refugee of the cell who are living without passport in this country. So what we are going to do? We are going to block these fake passports. So PDL1 को ब्लॉक कर दिया, CTLA4 को ब्लॉक कर दिया, T सेल आ गई, कहाँ है तुम्हारा पासपोर्ट? अरे पासपोर्ट तो मैंने ऑलरेडी ब्लॉक कर दिया. तो oh, then you are a malignant cell, I need to destroy you. So our own body is going to destroy this malignant cell, and this is the principle of immunotherapy. So I hope immunotherapy it is clear to you. And what is going to happen? So whenever you are going to block these molecules, so these molecules are nothing but, yes, so CTLA, so immune checkpoint inhibitors, anti-PDL, this is going to block the PDL1 pathway, and it can be given in AD advanced melanoma irrespective of the BRAF status. So in melanoma we checked for BRAF inhibitors, MEK inhibitors, and now something new upcoming is the immune checkpoint inhibitors. And another ticket which is going to block is the CTLA4 inhibitor. It might be combined with this again to have the synergistic effect. So BRAF inhibitors plus MEK inhibitors for BRAF mutant melanoma. Immunotherapy can be given to all advanced malignancies. Because the chemotherapy can have systemic side effects, you can give this type of immunotherapies which is going to target those specific refugees only and not the normal cells of the body, and that is the reason for action of immunotherapy. So I hope the action of immunotherapy is also clear to you. And something while going, we are going to discuss about isolated limb infusion. So let's consider that this is so there is a limb and there is going to be a squamous cell carcinoma of the limb. So I'm sorry I'm taking 2 minutes extra, but I hope that this is worth it. So whenever this is going to be the limb, there is going to be a squamous cell carcinoma here. You are going to do a wide local excision. So this is, the limb is going to only occupy around 20% of the whole body. So when you are administering a chemotherapy agent, it is going to go for the whole body. It is not necessary. So what do you do? So there are 2 techniques which you are going to do. One is going to be the single limb perfusion. So what you are going to do, you are going to take the limb blood circulation on a bypass machine. Very tedious process, and you are going to infuse high dose of chemotherapy agent. But this is more tedious. So what did they found? Instead of actually taking the limb on the bypass machine, you can just go for single limb infusion. So same thing which we are going to see in the liver tumor. In the liver tumor, we are going to go for TACE. What is TACE? Transarterial chemoembolization of the tumor. So chemotherapy given in the hepatic artery, and that hepatic artery will supply the tumor and only selectively kill the tumor cells. So similarly, we are going to infuse that typically chemotherapeutic agent in the specified limb through the femoral artery or the brachial or the axillary artery, and then the patient will have this single limb infusion of chemotherapy. So very much important factors, recent advance which is going on, but you should be knowing, I feel, because you all are attending these lectures and they should add to some benefit to you. So I hope I have cleared everything regarding the cutaneous malignancies pretty much in detail. Even you can write a long answer, you can see the patient in the OPDs and you can treat the patients accordingly. And I've also also talked to you about the basic benign conditions of the skin which you are going to encounter as a NEET PG MCQs, as the cases, and also you are going to see them in your routine practice. So I hope it is very much clear to you. Tomorrow we'll start off with the core plastic surgery, that is burns and the flaps of the patient. So till then, take care, bye bye, good night. If you have any doubt, you can ping me up on WhatsApp. I'm always available for all of you. Okay, chalo, till then, see you tomorrow. Take care, bye bye, good night.